Yes, friends, welcome back. So we'll discuss now, after knowing microbiology and different pathogen, the treatment. And history is very interesting. You know, the first anti-infective discovered somewhere before 1940s, they were sulfonamides, sulfas. They were the first drug discovered in Europe. And very soon after sulfur drugs, the first penicillin, that is benzyl penicillin, was discovered. So sulfonamides were bacteriostatic agent primarily, and penicillin was bactericidal. So the whole world started dancing that we got penicillin. So all the research from sulfa was diverted to penicillins. And the first penicillin was very powerful drug against gram-positive until today. Penicillin, benzyl penicillin, is the very powerful, most powerful drug against gram-positive bacteria, remember it. Now penicillin had some problems, like only parenteral use was available and short acting. So they made another penicillin which was long acting, and that was procaine penicillin, which was long acting penicillin. Okay. Then another penicillin they tried to develop, orally stable, orally active, and that group was isoxazoline penicillins. And cloxacillin was the first in that group, which was stable to gastric acid. Okay, and also working against penicillinase producing organism. Cloxacillin, many derivatives came after cloxacillin, like flucloxacillin, etc. Now, when penicillin started killing bacteria, they developed mechanism to overcome. They made an enzyme, penicillinase enzyme, which break the beta-lactam ring, which is in all penicillin. The activity of penicillin is due to this beta-lactam ring. So they break it and the activity goes. So this beta-lactamase resistant penicillin was discovered, and the first in the group was methicillin. And methicillin was only parenteral, and till today it is effective, but because of the high dose and better drugs, nobody is using. So orally active penicillin, as I told you, were discovered, and cloxacillin was the first one from the group of isoxazoline penicillin. But remember, till now penicillin is narrow spectrum, only gram positive. No gram negative coverage except maybe Neisseria gonorrhoeae and like that. So they developed extended spectrum penicillin, and the first in that group was ampicillin. And ampicillin ruled the world till 1980 or 1980, yes. They ruled. Ampicillin was number one drug worldwide, both oral and parenteral. Extended spectrum covering gram positive and some gram negative, particularly Proteus, but only mirabilis, with Neisseria gonorrhoeae and Neisseria meningitis. So these two organisms were covered, and also, but not penicillinase resistant penicillin. And penicillin had problem, absorption was only 45-50%, and diarrheal disorders were more with ampicillin. So they discovered another modification of ampicillin, but that was amoxicillin. Okay. Beautiful drug, absorption almost 90%, more than 90. So both oral and parenteral ampicillin is still better, because amoxicillin has no betterment over ampicillin in parenteral therapy. Only orally this is better. So you see how science and the development, pharmacokinetic development by industry and doctors are working in tandem. This is one example, but still it is extended spectrum. Then they discovered broad spectrum penicillin, and the first in that group was piperacillin. Okay. Then many other came, azulocillin, mesalocillin, ticarcillin. These are all broad spectrum penicillin. So friends, in different anti-infective penicillins were very widely used. So sulfonamides, chloramphenicol, penicillin. So from 6 amino penicillinic acid, from 6 APA, they made all the penicillins. Now penicillins are not much used except only one, that is amoxicillin with beta-lactamase inhibitor, that is clinalic acid. You know, the drugs like augmentin and all, they are used. So now after came a very important group, that is cephalosporins. And cephalosporins are today most widely prescribed anti-infective worldwide. And cephalosporin are bactericidal, broad spectrum, and remember, based on the different spectrum, they are classified into 5 generations. So there is a 1, 2, 3, 4, 5 generation cephalosporins. And this spectrum is absolutely based on gram-negative coverage. First generation, they are most powerful against gram-positive, remember, gram-positive. And gram-negative action is narrow. But they also cover penicillinase-resistant organism. So gram-negative is just almost just, So if I say 5 plus, then minus gram-negative coverage is 1 minus, 1 negative. Second generation, they have more activity. Now, first generation were cefazolin, cephalexin, cefadroxil, oral and parenteral, both were first generation. Now came the second generation, ciprofloxacin, acetyl and sodium. So what was ciprofloxacin? This is gram-positive coverage is same as almost 5 or 4, and gram-negative coverage now 1 become 2. So more gram-negative coverage is done. So second generation are also good drugs widely used. But when third came, the use of second generation was much reduced. Now third generation, they were gram-positive, same, not same, a little more, only 3 plus, but gram-negative coverage was 3. So they had activity against gram-positive and gram-negative both. And you know, ceftriaxone, cefotaxime, ceftazidime, all third generation cephalosporins are till today most widely prescribed anti-infective. But remember, you know, as you try to kill anybody, the organ, it is inbuilt. God has given this capacity that they will develop mechanism to overcome the killing. So they started manufacturing the cephalosporinase enzyme, which destroys cephalosporin like penicillinase. Together we call them beta-lactamase, just to say. Okay. Now came, but remember, in among gram-negative bacteria, some are very tough organism, you know, particularly Pseudomonas aeruginosa. So this gram-negative bacteria is very tough to kill. So some third generation, particularly ceftazidime, is the best for Pseudomonas, better than ceftriaxone, cefotaxime or others. Okay, but fourth generation, they came, so they were 3 plus against gram-positive, and against gram-negative, they were 4 better than third, because they also cover Pseudomonas aeruginosa. So they are covering gram-positive, gram-negative Pseudomonas. Cefepime and cefpirom, these two are available parenteral. Okay, but and also resistant to penicillinase. Now fifth generation also has come. So they are very powerful against gram-positive 3, and they are very powerful against gram-negative, even more than fourth that is coming. You know, you can say 5. Plus they cover also beta-lactamase and also resistant organism to vancomycin or to methicillin. So that is what is there. One drug, ceftriaxone, is available, and in some countries, in India, I am not sure, it is not available, but will be used after some time. So this is how cephalosporins they came. Okay. Now another group of anti-infective came after cephalosporin, that is your fluoroquinolones. You know, fluoroquinolones are not antibiotic. Don't say antibiotic. They are chemotherapeutic agents, anti-microbial. And the first was norfloxacin. Until today, norfloxacin is used, but pharmacokinetically it is not penetrating in the tissues, only local in urine high concentration and in intestine. So only diarrheal disorder and UTI are the indication, nothing else. Some people are promoted for typhoid also, but that is mispromotion and not good. Such, I don't appreciate such pharmaceuticals. So only 2 indications for norfloxacin: diarrheal disorder, you know, and intestinal and urinary tract infection, complicated resistance cases. So this was quinolone. Now they added fluorine atom and they improved the bioavailability and the absorption. So came fluoroquinolones. And the first in that group was ciprofloxacin. After so many, emifloxacin, sparfloxacin, moxifloxacin, getifloxacin, so many floxacin, but they are all of the same group. And remember, they are very powerful. They are against gram-positive, gram-negative, including penicillin is resistant. Okay, so this penicillin came. So fluoroquinolones. Now, parallel to before that, and another class of anti-infective was aminoglycosides. So the first one was gentamicin. You know, somewhere in 1990-95, garamycin or gentamicin was number one prescribed parenteral for gram-negative, not for gram-positive. Because for gram-positive, you have penicillins and all. So as an expert in the anti-infective, you should know which anti-infective to promote where and what is good where. Although aminoglycoside cover gram-positive, but they are recommended only for aerobic gram-negative infections, not for anaerobic, remember. Okay, for anaerobic there are other drugs like imidazoles, metronidazole and others. So, aminoglycoside, gentamicin, then many, they had some problem like nephrotoxicity, ototoxicity and also neuromuscular toxicity. So, some were developed from gentamicin like nitilmicin, amikacin, a beautiful drug. Okay, but remember they are all only parenteral. So aminoglycosides were discovered. Then before that, very unknown, there is macrolides. Erythromycin is a very old drug, used widely, gram-positive, gram-negative and oral. And many macrolides came. And remember, macrolides have broad spectrum right from chlamydia to the bacteria, broad spectrum, very broad. So after erythromycin, then roxithromycin, then azithromycin, okay, clarithromycin, all they were discovered, you know. And azithromycin is very popular now, used due to respiratory problem because of mycoplasmic coverage. Okay, because mode of action is not break the cell wall, but they break the not cell wall synthesis, but they inhibit the protein synthesis. So macrolides came. This is one group, macrolides. Then another group is also very close, lincosamide is also one group. Okay, and very another is glycopeptide group, very widely used, and they are active against methicillin resistant bacteria also. So the one was vancomycin. Vancomycin had some problem, then came teicoplanin, and some more are coming. And another is oxazolidine. You know, so these drugs like linozid, so they work also, you know, in vancomycin resistant cases. So if there is resistant to mycin, they work. So remember that as an anti-infective, there are different anti-infective depending on the spectrum, depending on the resistance to antibiotic. A clinician can use whatever. I give you a small example, gentlemen, before I close my subject. Okay? So this will tell you why there is a need for so many antibiotics. Now there is a disease, urinary tract infection, very common, mostly in females because of anatomical positioning, okay, of the organs. More are in female, but male also they suffer. Now urinary tract infection, you can give any antibiotic, all whatever you want to give. If there is a small girl with UTI, you know, and she is not sexually active, so it is uncomplicated UTI, just give amoxicillin or ampicillin is good enough. Nothing else is required. Now same girl, if you know, she has a recurrent UTI every time, maybe that you need another drug, so you can give cephalosporin, cephalaxin or cefaclor or even cefixime you can give. Okay, because it is now spectrum maybe more, you know, and she is getting recurrent UTI. Now same girl, if she has you know, recurrent UTI and not responding to them, you can give fluoroquinolone, you can give norfloxacin also, very wide, you know. But suppose during pregnancy these are contraindicated, so you cannot give norfloxacin. You can, you know, you can give safer drugs, nothing like penicillin. Remember, during pregnancy, category B, penicillins are the safest during penicillin. As such, nothing is safe, no the A class drug is available. But looking to the benefit risk ratio, this is pregnancy category B, penicillin and cephalosporins. So norfloxacin you can give. If the same girl is hospitalized, oral therapy is not possible, you can give amikacin sulfate in UTI. Beautiful drug actually. And gentamicin you can give. So you see, you can give penicillin, cephalosporin, fluoroquinolones, aminoglycoside, and if you suspect some atypical pathogen in UTI, for example, in some sexually transmitted disease, couple disease, reproductively, the active. So you can give also now macrolide. You can give azithromycin in UTI. You can give erythromycin in UTI. So you can also give them different, even tetracyclines also in UTI, doxycycline particularly. But remember, during pediatric use and during safety pregnancy, not to be used. So in one indication, you can give 20 anti-infective. Now the subject is very vast, but I am sure you as a promoter will appreciate today that if you have even 10 anti-infective in your company, all you can promote depending on by positioning some anti-infective for some indication and where other are not good, so that a product manager will do the job. But for you as a promoter, this is also very important. So I hope you have enjoyed today the session. That is the about anti-infectives available. Okay, so have a good time. See you in next video. Bye.